Now there is another important session about the open surgical necrosectomy. Is there still a role, particularly with the advent and advances in the percutaneous management and endoscopic management? So is there any role for open surgical necrosectomy? Dr. Vikash Gupta.
Yeah. Thank you, Chairpersons. At the outset, I would like to thank Dr. Sanjay Mandal and the organizing team and IASGCON for giving me an opportunity to speak in this forum. So when the endoscopic procedures have evolved so much, so is there a role of open necrosectomy? That is the question for me, which I have tried to answer, because it's not only the open necrosectomy which is required in the setting of pancreatitis. There are many more situations where we need to do an open procedure in pancreatitis. So what is already established in the treatment of pancreatitis is the step-up approach. All patients should be subjected to step-up approach, and only the treatment failures will undergo some kind of drainage procedure. And whenever drainage is required, it has to be delayed beyond 4 weeks. And question is how to do the debridement. With the evolution of minimally invasive techniques, endoscopic, ward, and all those techniques have been widely used in debridement, the role of open surgical necrosectomy is limited and contracting day by day. So why this question has arisen? Because of the increasing armamentarium from the intervention radiologist, endoscopic intervention in the form of direct endoscopic necrosectomy, LAMS, minimally invasive ward, transgastric laparoscopy, all these many procedures have been described, and one or the other procedure fits in a patient, but still that is why there is a question whether it is, as of today, is it required or not. When I was given this topic, I tried to search the literature on open necrosectomy. In the last 5 years, what I found is publications on minimally invasive necrosectomy 69, endoscopic necrosectomy, endoscopic procedures 138, open necrosectomy 15 publications, and those pertaining to comparison with the endoscopic techniques where it is open is being criticized in the form of increased morbidity, some meta-analysis, those kind of things. There are very hardly 1 or 2 series which I could encounter of open necrosectomy in the last 5 years. There is always a publication bias. We all know if you send a paper with so many open necrosectomy, it will outrightly be rejected because open necrosectomy is not the norm of today. So to my mind, when open surgery is required, maybe after the failure of step-up approach, what are the situations when we do upfront necrosectomy by open technique? It is obviously required as a rescue procedure when endoscopic or other minimally invasive procedures have failed, or it may be required when a complication arises as a result of pancreatitis or as a result of some intervention which has been done earlier. So are all infected pancreatic necrosis suitable for minimally invasive techniques? And all of us will agree to it that no, all infected pancreatic necrosis are not suitable. What we see here, when a pancreatic necrosis is lateralizing to the left and it is in the body and tail of pancreasing, lateralizing to the left pararenal spacia, this gives a good window for drainage. Ward can be done and minimally invasive necrosectomy can be accomplished. Like in this picture, what we can see here is a big cyst in the retrogastric area. This is absolutely suitable for endoscopic necrosectomy and laparoscopic transgastric necrosectomy as well. The problem arises when the necrosum is largely onto the right side and it is extending into the right pararenal area. There we don't get a good window for drainage. Then open necrosectomy can be considered if the patient requires. So availability of the safe window is the main driving force which will determine what kind of procedure is required. This is again the same thing where the left pararenal area can be accessed by the ward technique, retroperitoneal debridement technique. Endoscopic gastrostomy can be done for the retrogastric collection, and for the right-sided collection, this is right-sided collection going into the pararenal area, open surgical drainage will be required. So second indication where open will be required is when one realizes that can you achieve the complete debridement using minimally invasive technique. So again, the answer will be no. In all patients are not suitable for that, because when the necrosis is very extensive, the patients will require multiple sessions, multiple procedures, and I don't think it will be always possible in our setup to do necrosectomy in so many situations. When the solid component in the necrosome is high, because there is many walled off necrosis are being subjected for endoscopic and laparoscopic management. When the solid component is very high, presence of extra pancreatic necrosis and of course right-sided necrosis is there, then these patients can be subjected for open necrosectomy. This is again an example to show the necrosis extending onto the right paracolic gutter. Entire pancreas is involved into the right paracolic gutter, left paracolic gutter, and I think it is better to go upfront and do necrosectomy whenever this patient is suitable for the procedure. Similarly, this picture shows lot of necrosis in the pancreatic bed from the left, replacing the entire pancreas. Lot of air is there, and again this patient should also be subjected for open necrosectomy. And this is what was done. We did through the lesser sac, we opened the pancreatic bed and did the necrosectomy, and see the amount of necrosome which has been removed here. So surgical approach has also changed. What we can see here is transmesocolic approach, which was usually done when open necrosectomies were being performed widely from to the left of the middle colic artery, and it could serve the purpose if the necrosis was limited largely to the left side of the pancreas. And with the more and more selective use of open necrosectomy, we need to go to the right side of the middle colic artery to achieve the complete debridement. Another important component of open surgery is management of complications, which can be largely which complications which require surgical intervention will be hemorrhage, GI fistulae, colonic fistulae, iatrogenic complications. So hemorrhage we can see as hyperdense content on CT, or when a PCD is put and we see such a gush of blood into the bag. So 10 to 15% of the patients will experience hemorrhage during the course of pancreatitis. It is established that upfront intervention radiological management is the most suitable method of managing hemorrhage, but there are situations where surgery will be required, and this is what we published about 3-4 years back, that about 16% of the patients who had hemorrhage associated with pancreatitis required surgical management. And whenever surgical management is required, it is usually catastrophic and the mortality is usually high. And this is we published about 2 years back, the management algorithm in managing the hemorrhage during the course of pancreatitis, where we can see that if after attempting to localize the bleed, if we are able to localize and embolize with intervention radiological technique, it's fine. But if the bleeding is not localized, and if the intervention radiological technique cannot be successful, or the patient is not stable enough, then surgical management will be warranted. And again, these bleedings where we are not able to localize are usually venous ooze from the pancreatic bed, and where we cannot do much about it. We just have to go in, do the completion necrosectomy, pack and repack. That is what is warranted in this situation. Colonic involvement is suspected whenever there is lot of air in the pancreatic bed, and about 10% of these patients will experience colonic necrosis. And this is again an example to show lot of air with a fluid collection, and the radiologist put a PCD in it, and it directly drained the enteric content. So there is worsening of sepsis, and these are the patients who will again require completion necrosectomy and urgent surgical intervention. This is again to show a colonic perforation, de novo perforation developing, and again showing a perforation as a result of PCD inserted through the colon into the necrosome. So when we see the type of colonic involvement, this is a recent study from in 70 odd patients. And we see that colonic involvement can be in the form of fistula, inflammatory stricture, perforation, ischemia, or fulminant colitis. And amongst this, where do we intervene in acute phase is perforation and the bowel ischemia, because fistula formation and inflammatory stricture formation is always a delayed event. Mostly the patients will have undergone a diversion or so, and they will be tackled subsequently. And again, when the colonic perforation or gangrene is there, again the debate is between doing a simple diversion or resection. Diversion is warranted when the patient is unstable, you cannot do much about it. So simple doing a diversion and can control some amount of sepsis. However, resection should be the preferred modality, particularly when the patient is stable, as the loaded colon distal to the diversion will be full of bacteria and it will keep on contaminating till the colon empties. So it is always better to do a short segment, subsegmental resection, and most of the times what it was seen in this study was about transverse colon and the right colon is the segment of the colon which is usually involved. If a perforation is there, perforation is localized, we should never attempt to try to close the perforation, because the whole area will be inflamed and sutures will cut through, and again the perforation will, what is small perforation is there, you try to put suture, it will increase in size. And again, this was seen that if there is colonic involvement, the morbidity, hospital stay, mortality, and readmission rates, everything increases with colonic involvement. This is what our experience is. We published it about some time back, and we had 4 cases where transverse colon was involved in chronic pancreatitis. All of them required surgery, and about 50% of these patients died in the postoperative period. GI fistulae, foregut fistulae are again common to form, but again formation of foregut fistula is at times can be a favorable event, because there can be spontaneous drainage of necrosum into the foregut through the fistula tract, and sometimes endoscopists can use this fistula tract to complete the debridement. But again, whenever the fistula gets uncontrolled, whenever we see biles coming from the percutaneous drains, we need to go in and do intervene in these patients. But again, these patients also have a very poor outcome, because what we can do here is put multiple drains, try to make it a controlled fistula, establish enteral feeding line, and then we can try to control sepsis in these patients. But again, this is fraught with high mortality. This is our experience again with proximal fistulas, where conservative management was successful, and those who required surgery eventually died. Endoscopic complications arise as a result of inadequate and incomplete drainage, malpositioning of stent, displacement of stent, and iatrogenic perforation. This is, we recently published, we saw a patient with LAMS into the, through the transgastric LAMS into the pancreatic necrosum, and subsequently the LAMS had slipped into the pancreatic cavity, where we had to go in again and take out the stent and complete the necrosectomy in this patient. So what are the challenges which we face after endoscopic failure is delayed, there is referral is delayed, sepsis is florid, and particularly if transgastric procedures are done, then open necrosectomy again you do, open the lesser sac from the transmesocolic or lesser sac approach, risk of gastric fistula is always there. So this is again recently published in American emergency surgery, when should open necrosectomy done. For one is treatment failure, presence of bowel ischemia or perforation, opening up the abdomen for simultaneous indication, and again doing a need for cholecystectomy is not a valid indication for doing a open procedure. But last couple of slides. Again, these are
Dr.
American.
Vikas, we are exceeding the time.
Sorry?
We are exceeding the time.
These are the American gastroenterology guidelines, wherein the approach to debridement, again retrogastric collection with extension into the right and the mesenteric vessel can be done by endoscopic, laparoscopic or open debridement approach. So to conclude, I will like to say that indication of open necrosectomy are decreasing and contracting, particularly it is reserved as a rescue procedure, and complications arising as a result of disease process or intervention can force you to intervene in these patients. Thank you so much.
Thank you, Dr. Vikas, for that wonderful talk. What is your take on endoscopic versus open necrosectomy for early necrosectomies? See, the timing we all know, but if you are forced to do a necrosectomy very early in the disease process, say 3rd week or so, for various reasons. So is there any clarity about endoscopic versus open necrosectomy in such cases?
As such, I could not find any literature directly comparing in early phase. But again, whenever feasible, endoscopic or minimally invasive necrosectomy should be done, until unless there is a fairly good reason not to do it.
Thank you.
Hi, Dr. Vikas.
Hi.
As we saw, the gastric perforations are difficult to deal with in these cases. But many times now endoscopists are fairly dealing with and putting in a stand from where they can do repeated necrosectomies. So you've seen or dealt with few patients where the stent slipped. How do you propose to deal with it?
That is a very difficult situation. So if the stent has that is what we published about last year only. If a stent slips into the cavity and patient sepsis has already resolved, pancreatitis has already resolved, you let the stent be there, wait for 6 weeks, 8 weeks, and then go in again and take out the stent.
No, patient
But-
is having persistent fever.
But if the patient is having persistent sepsis, then you have to go in again and do a gastrostomy, do some kind of decompression. That is the problem which has never been, which is not highlighted. I couldn't find any literature on necrosectomy after the endoscopic failure of transgastric procedures. I could not find any any reference on that. But that is the practical problem which we have been facing, that after a transgastric has been done, it becomes very difficult. Patients eventually land up in having a gastric fistula.
Gastric fistula.
Yeah.
Thank you.
Last question.
Dr. Vikash, excellent lecture. Just may not be related to your lecture today, but just because you are so experienced, any experience about intervening in abdominal compartment syndrome early in the phase?
Yeah, sir. In fact, about 10 years back, when we were directly admitting acute pancreatitis in the surgical wards, we had a couple of situations where we had to do laparotomy to relieve the abdominal compartment syndrome. But as of today, for the last maybe around 5-7 years, early phase of pancreatitis is being managed in the gastroenterology ward. So where they have been doing with ventilation and doing a percutaneous PCD for drainage of ascites to manage the abdominal compartment syndrome. Of late, I don't recall, and in the last 5-7 years, doing any laparotomy early in the phase of acute pancreatitis to decompress the abdominal compartment syndrome.
Thank you, Dr. Vikas.
Thank you, sir.
And take this opportunity to thank all the speakers for this wonderful session. Thank you.